And radio. We're broadcasting from our studio at 3 Wesley Street off Demby Road in Freetown, Sierra Leone's capital.
Coming up in the program this morning, the Ministry of Tourism and Cultural Affairs and partners will, of course, tomorrow kickstart a 3-day Women in Tourism Regional Congress aimed to advance beyond empowerment by equipping women in tourism with the requisite access needed, among other things.
And we shall be evaluating the country's health sector, as we'll be speaking to the Minister of Health, Dr. Austin Demby, on his plans to improve the healthcare system in the country.
Just a gentle reminder that you're still watching Wake Up Sell on AYV television, on channel 33, on radio 101.7 FM, and on DSTV channel 399. Similarly, so on our Facebook page, where we do, of course, ask that you send us your comments, questions and contributions, and as we go along, we'll have to go through same. I think now in our first segment.
We'll start off our first segment. In the studio, we've been joined by the country's Minister of Health, Dr. Austin Demby. The minister is here to talk about the country's healthcare system, ways to improve it, successes and challenges. Good morning. Thank you for joining us.
Good morning, Fabian, and good morning to your viewers.
Good morning.
You've had, the opportunity of staying longer in office, even with the reshuffling that's been going on. You've conveniently secured your spot as Minister of Health and Sanitation. What progress have you made in the healthcare system?
First off, I want to be grateful to His Excellency the President for granting me the opportunity to continue to serve. We don't take it lightly, because there are about 8.5 million of us, and so if one person is picked to do a particular job, it's an honor, and it's also a privilege. I think one of the things in the healthcare system that we need everybody to understand is that we're radically changing the way healthcare is delivered in this country. For the past 20, 40 years, there's been a deliberate focus on diseases. So you have a malaria program, a TB program, an HIV program, a nutrition program. And so one of the things that I am focusing on, I don't want to have the best malaria program and somebody dies of typhoid or somebody dies at childbirth. In that case, we are lost. So we're shifting the focus from a disease-specific to a person-centered care. We're looking at the person. We're looking at a 360 around the person. So when this person presents in the hospital, we want to see all aspects of their health. And so you can imagine an institution that's been built one way and you're trying to shift it the other way. But it's very profound. We've made tremendous progress. And I think what we want to do is to have all 8.5 million of us see ourselves in the healthcare system, and the healthcare system sees everybody. And that's what we're calling universal health coverage. And the best way to do that is to follow the life stages. What that means is we look at the pregnant woman and just say all of the 300,000 to 400,000 pregnant women, how do we provide services for them so that they remain healthy and they deliver safely? And so we set targets, we work towards those targets. And when the baby is born, we say, you baby, you're here now, you're a new citizen. From age 0 to age 6, what kinds of services do we provide for this baby to ensure the baby doesn't only survive, but the baby thrives? In preschool, how do you make sure that this baby is ready for school? When the kid is in school, the kid is focusing on learning. How do you make sure their health needs, their hearing, their eye, their malaria, their TB, all of that is taken care of to let them focus on their education till they become teenagers and they become young adults and senior citizens. So we're following the whole life course approach, and we're looking at in each stage to see what interventions we take and set targets. The cool thing is setting targets. We're beginning to see the results. For example, just looking at pregnancy, we've been able to dramatically reduce maternal mortality in this country. It's not only reducing maternal mortality, but improving maternal health, such that we're the fastest drop in maternal mortality in the whole continent. Even as we speak, we're expecting some visitors from Burkina Faso and from Botswana in the month of November to come and see how we did it. For young babies, for young, we focus and say, look, we're going to reduce childhood death, infant deaths dramatically. And so what that means is we ensure that there is zero child that hasn't been vaccinated. Zero those children, we bring it down to zero. Make sure all of the children have their vaccinations in the right regimen. Make sure the nutrition is taken care of. Make sure the malaria is prevented by making sure that the bed nets are available, insecticide bed nets are available, and malaria vaccine is available, and ensure that we have rapid diagnosis and treatment. And the same thing for young adults. We're looking at the HIV rates in the country and to see how do we better manage HIV infection and prevent it such that we're able to reduce the deaths associated with it. And for people who are infected, ensure that they have the right medications and they're able to carry on their treatment and live a normal life. The same with TB. We ensure that with TB, 80% of all of the TB cases have an underlying HIV situation. So we don't want to separate them, we want to deal with them, but at the same time. As we're doing all of these things, the human resource is very critical, and so we're looking at training more doctors, training more nurses, and it's not just basic training now, we're looking at postgraduate training to bring specialists in. Just a few weeks ago, we graduated the first 8 OBGYN surgeons who were trained here in Sierra Leone in their postgraduate training. Now they're members of the West African College of Surgeons. So that's going on. The nurses are training, the community healthcare workers are training, and I think we're really beginning to show changes. It's not right away, but you begin to see the changes, the shift in focus.
Before we delve deeper on into some of the issues, let's get to understand, in the previous administration of President Ernest Bai Koroma, he had made a priority. As we speak, what's the current status of that free healthcare program? Because there were countries that were also supporting us with the medicines. What's the status of that free healthcare?
Free healthcare is alive and well. The free healthcare, the previous administration started it, and we've expanded it. We've expanded it because now the free healthcare is for all pregnant and lactating mothers. It is for Ebola survivors. It's for the most vulnerable people. It's for handicapped people. And so it's broadened the scope a whole lot more. The partners are still with us, but the arrangement was the partners will slowly wean themselves off as the government takes greater responsibility. The problem with free health care is it's directed at a small group of people, the most vulnerable, pregnant women, lactating mothers, children. But I think what we're worried about is what about everybody else that does not qualify for free health care? So what we're doing now is to try to actively launch an insurance scheme, a health insurance scheme, that will allow people to pay a small premium and be able to pull the risk. It's not everybody that breaks their leg, it's not everybody that has malaria on the same day, but if we all pull a small amount of money for ourselves, we will be able to make sure that if one of us gets sick, we're able to use those resources for it. So the free healthcare is alive and well. We've expanded the scope. We're trying to complement it now for those that don't qualify. So fairly soon we will be launching the health insurance scheme, but we want to launch the health insurance scheme as part of a broader approach. We want to have universal health coverage. Universal health coverage means health for everybody. So if you have a small group of people who are covered by free health care, we want to have the other group, the other complementary group that's covered by a health insurance scheme with minimum premium associated. When you combine these two, that is the approach we're taking to universal health care.
The transition from a disease-centered to that of a people-centered makes a lot of sense. But again, taking into account, this is a sector that has been budgeted for about 6 to 7% of the country's budget allocation. And this comes in with a lot of shortcomings within the health sector. Taking into account, many will say it seems very much underfunded. How is that impacting health outcomes for particularly the country?
Well, you know, I think we all had the Abuja Declaration where all the countries in Africa agreed to have like 15% of their budget allocated to health. And so a lot of countries have been working towards that. I think for us in Sierra Leone, we're aggressively moving towards the Abuja Declaration. I think at last we were like at 11% or so, which is much higher than a lot of countries. But I think having said that, when you look at the economy of the country, you're looking at 11% of what? You know, we're in a very, very difficult financial state. So the 11% is we're very pleased with it, but it's a small amount of money, you know, compared to the need that we have. So what we're doing is, as we try to slowly increase the amount of resources that's going to health, we're looking to work with our development partners to help us bridge this gap. So, for example, at the last budget iteration, the operational cost for the Ministry of Health was about $50 million or so, so for 8.5 million people. But so we had to go raise another $300 million from our friends, our colleagues. So I think we're just getting the balance right. We always need more money. We always need more resources to be able to provide the kind of health care we deserve in Sierra Leone. But in difficult financial times, we want to make sure that there's value for money. Every dollar that's invested, every Leone that's invested in healthcare, we want to make sure that Sierra Leoneans derive the best value for it.
Over time, we've seen many partners who've come in to, of course, help capacitate the health sector, of course, make things better. One of which is that of PIH. We've seen them supporting 6 districts over time. But again, let's have a holistic look on the health sector, particularly so for those in vulnerable communities, say provincial areas. The facilities could be one, and access to those facilities, adequate facilities is another thing. Is the ministry still concerned with the problems those communities continue to face?
I think you're very right. You know, when we say universal health coverage, it means health for everybody. You know, you have to be able to make allowances. It's not just people in Freetown or in the urban areas in Bowen, Kenema, and McKinney. You want to look at people all over the country. Now, I just want to remind all Sierra Leoneans, we were the ones that actually read the Alma Ata Declaration in the world that set primary health care as the most important way of delivering healthcare services. What that means is taking healthcare as close to the people as possible. In Sierra Leone, for the past 40 years, we've invested very, very heavily in taking healthcare as close to the people as possible, such that for 85% of the population, you have a health facility within a 5-kilometer radius. That is progress. That is higher than most countries in the continent. What we're focusing on now is how do you bring quality to that access? So we're looking at 4 domains of quality. One is infrastructure. Physical infrastructure. You have to have a building that somebody will want to go to. It's clean, it's safe, it's got energy requirements, now we're transitioning from all of these generators into solar energy and ensure that there's water available there. That's physical infrastructure. We're looking at personnel and ensuring that you have the right number and the right mix of personnel in these facilities. The third is equipment, ensuring that the right equipment is there and the supplies associated with it, and drugs. So with those 4 elements of quality, what we're looking at now is of the, I think it's about 1,600 facilities in the country. We're looking at each and every one of them to see if they meet those quality requirements. And our role now is to expand those and make sure that those quality requirements are met. We want by 2030 to increase it from 1,600 to 2,000 facilities. Now what we're doing is all of these new facilities, you're not going to see a generator there at all. We're going to ensure that they have solar panels and ensure that the water and the energy requirements are met in those facilities.
But again, even as we talk of the transition to clean energy in these hospitals, it's very clear, and you're also aware of the fact that governments seem not to be taking the lead in furnishing most of the facilities they have. Take, for instance, Connaught. As we speak, it has no functional CT scan, Dr. Demby.
Well,
It's making the situation much more worrying towards these government hospitals.
I take your point, but have you been to Connaught lately?
I've been to Connaught.
I think you should. Maybe next time you and I should go in there. It's transformed. It's transformed radically from the outpatient department into the actual wards themselves, into the specialty units, the stroke unit, into the children's unit, into the surgical theaters. We're building the burns unit there. You have the doctor's hostel in there. It is transformed. Right now, they have oxygen factory in Connaught that pumps oxygen directly into the ICU, the only true functional ICU in the country. All of the top doctors.
You say true functional ICU in the country?
The true functional ICU, the most important one. I mean, they have other ICUs. Choitrams has, a few of the others had. But if you really want to have a truly functional ICU, Connaught is your place. So I get the point that we need to upgrade, we need to uplift things. But I think let's recognize what has happened so far. What we're trying to do, again, for your listeners, for the past 40 years, we've focused on primary healthcare, as I indicated before, which is really great, which is more taking healthcare to the people. What we hadn't invested enough in is secondary and tertiary care, the bigger hospitals, because quite frankly, everybody's worried, how do I put money into expensive doctor training, expensive hospitals? What we've been doing now is to rebalance, double down on primary healthcare and bringing quality to it, and invest in hospitals now as well as a complement. So you don't want failures in primary healthcare and you don't have a landing zone in the secondary and tertiary facilities. So as you could see that there's major activities going on now to build up the secondary and tertiary facilities. Connaught is paramount. PCMH, I just went there and we opened a new outpatient department and a new pharmacy bought there. You have the new children's hospital at Lumley that we're building. We just got $50 million to build a brand new state-of-the-art hospital at Kerrytown. We're working on a $100 million hospital in the center of the country between Bow and Kenema. As you said, with PIH, we are working on the Connaught Hospital to be open in the next few months. So there's a lot going on. As we speak now, I'm going to break ground on a new hospital in Moyamba, Pujong, and Karine. There's a lot going on in the hospital sector as we complement what's going on in primary healthcare. I think when we started out, I told you that we're focusing on patient-centered care. What I want us to do is to not be distracted by flash in the pan, the big flashy things. When we build a hospital, we want it to be truly functional. When I mean functional, it has the equipment, it has the supplies, it has the personnel, it has the expertise, it has patients at the center, at the core of the activities. That's what we're doing.
Dr. Demby, let's talk about doctoring the doctors.
Yes.
Few days ago, we had the Secretary General in the studio talking about their strike. The thing is, the doctors work under such strenuous circumstances, from inadequate water supply, electricity supply, even supply of medication for those supposing to be benefiting from the free healthcare. Long duty calls. They complain some of the hours are crazy long without even a provision of food supply. No increment of salaries for almost about 15 years. This is affecting their mental health. And these are the people who are supposed to be performing surgeries, supposed to be diagnosing whatever is wrong with people, treating them. How do you doctor people when you yourself, you're not in the right mental frame?
Fabian, that's a very important issue you raised. You know, again, as I was saying, the hospital is not a building. The hospital, it's its function, you know, what happens in there. And the doctors are central, they're critical to this work that we do for patient care. Their well-being, their welfare is vitally important to this government. To start with, most of the doctors, nearly 100% of the doctors, All of their fees are paid by government of Sierra Leone, by your taxpayer money, to get their training, including postgraduate training. When they go out overseas for training, we ensure that the scholarships are not given to individuals. They're given to the country, and the understanding is they will go and train and come back to the country to support it. Yeah. At the same time, as I was saying, it's really important to look at the 360 around doctors. First, you need to look at what is needed. For 8 million people, we need about 5,000 doctors. We only have about 500, 600 doctors truly functional. So there's a huge deficit there. So we need to be able to forecast the need and train towards that need. As you train towards that need, make sure that you bring in all of the new skills, the new technologies, the new things that will make them truly functional. As they train, you want to deploy them.
How do you bring that in when those who are currently in the field don't see it maybe viable? The Secretary General spoke about a survey they did. Just a minute, Dr. Demby.
Yeah.
He spoke about a survey they did, and part of that survey, only 20% of the doctors we have are willing to stay home and serve.
Yeah. Can I land? Okay, I said you forecast the need, you train towards the need, you deploy based on the need, and you focus on retention. So that's the piece that I was coming to, on retention. Retention has a lot of issues that will let people stay. We've trained about 1,500 doctors over the past 30 years. Only 500 of them are here. The rest have gone. So what we need to do is to be able to figure out a way to retain these people. It comes in compensation, and we're looking at that. It comes in with privileges, we're looking at that. It also involves giving them the tools to be able to perform their trade, and ensuring that you could stay here and be actively involved in impacting the health of your people, but also be globally relevant by being involved in active research. So what we're looking at is to say these young people, after their training, in the past you have to go to Ghana or to go to UK or where, for your postgraduate training. Now we're offering postgraduate training here in country. You know, and as you're doing your postgraduate training, there are opportunities to be actively involved with an R1 grant or an NIH grant, you know, where you could have phenomenal resources made available to you that will help you with your patient care as well as your remuneration. So we're looking at creative ideas to ensure we retain these staff. Yeah, again, we all think that we're a very, very wealthy nation. I think that's correct. That's very true. We're a very, very wealthy nation. But we're going through a difficult financial crunch as a nation. So when you have these difficulties, the hurt is spread all around, and we try to soften that for healthcare workers. So, I mean, in a lot of places you sign a contract that after your training, the government pays for your training, you serve them for 5 years or 6 years or 7 years, you know. We don't have that, you know, and people are doing it because they feel that they have a duty to help their community. So again, we have to meet halfway and support them and make life easier for them and make opportunities available to them, even as they serve. You could go to Ghana and make more money. You could go to UK and make more money. You could go to the US and make more money, yeah? But if the people of Sierra Leone paid for all of your education, and then you go and benefit Ghana, and benefit the UK and benefit the US, is that fair to Sierra Leone?
But it also concerns them that when they go for trainings or so, they perform better than even their counterparts in Ghana. Academically, they perform better.
We're so proud.
Yet we still have our people choosing to go to Ghana in trust, in confidence that they would offer better services and facilities, trusting that their lives could be safer in the hands of the Ghanaian doctors in Ghana than our doctors in Sierra Leone. Why is that so?
This is really, really important. It is building confidence in the Sierra Leoneans to utilize their own services. You go to Ghana, you go to all of these, you go to the UK, and you go to Birmingham, There's Sierra Leonean doctors. You go to Maryland in the UK, in the US, there's Sierra Leonean doctors who are thriving, who are doing extremely well, yeah? And some of them are here. Yet, you know, you go to Ghana and the Ghana doctors are saying, why are you here? When you have the top cardiologist, Dr. Russell, in Freetown, yeah? So what we want to do is to do two things. First, build the institutions, you know, build the Connaught of the future. You know, just go away from that history of 3 years ago. When I was here 3 years ago, people were throwing dirt at Connaught. Go and change that reputation, that track record. If I am sick, I'd rather go to Connaught than to go anywhere else. So we need to rebuild the confidence. We need to rebuild the doctors. We have specialty training now for OBGYN, for pediatric services, for psychiatry. You know, here in Sierra Leone, we're only training Sierra Leoneans. We're going to be bringing people from other countries to come and train here. So again, I think we need to have confidence, because I don't blame somebody who wants to go overseas for their care. It's because they don't trust the system here, even though empirically it's better than where they're going to. So we want to build a system here. We want to build trust here. We want to make sure that we use these services here ourselves. And we're expanding it. I just bought, I'm in the process of buying 2 CT scans from a friend of ours who just gave us the money for it. We'll put one in Connaught as a public hospital, and I'll take one to Kenema. And we'll raise some more money to have CT scans in all of these facilities. We want imaging, we want diagnosis, we want critical care. I'll tell you something. You remember there was one story with that young guy who had his tibia broken, snapped, and he was hovering around for a whole year, and it was an internet sensation. That kid was identified. It took him to all of these places. They said, amputate the leg. We were told, if you don't amputate, this kid is going to die in about 48 hours. I said, let me get a second opinion. We got a Sierra Leonean surgeon and looked at it and says, I've seen this before. It's incredible. This guy is the bravest kid I've ever seen, because there are 2 bones in the leg. One is the smaller bone, one is the bigger bone. The bigger bone is the one that snapped. And since he's been hobbling around, he's built strength in the smaller bone. And the doctor said, we're not going to cut this leg, we're going to salvage it. He was able to repair that leg, and to the chagrin, to the shame of all of these other experts who were saying, cut the leg, the kid is roaming around happily. So we have good doctors here, we have good surgeons here, we have good people. All we need now is to increase the facilities for them. I don't know if you've been to the new pediatric facility over at Lumley. Please, you should go there. When I walked in there, I nearly wept. Because this is what you see in Europe, this is what you see in America, this is what you see in Australia, in terms of facilities, in terms of equipment, in terms of space. That's what we're trying to build.
Dr. Demby.
Yes, sir.
With the current unfolding of things, see, for the past 15 years in Sierra Leone, it tells you we have people who are faced with a lot of mental health problems in the country. But the other day we had Dr. Jallo, who is the lead psychiatrist in the country, who says they are still challenged in terms of operations and activities. And again, as a country, it seems more like we have only one psychiatric hospital. Say for those in other parts of the country, Kenema, McKinney, so to speak, they seem left behind in that regard.
I think this is one area in healthcare delivery that we haven't given the focus that it deserves. You know, I think mental health is, again, it's critical. Mental health is a major component of health. And if you don't have that, you really don't have health. Unfortunately, we've focused a lot on infectious diseases and clinical medicine, and we haven't focused on mental health enough. So it's not right that we have just one psychiatric hospital in the country. Over and beyond that, mental health is not just what you see as the psychiatric cases. Mental health is a continuum. And we have to be able to deal with this continuum, from stress management, from managing simple issues around agitation, around management, around social interaction, to ensure that you don't graduate to where you need psychiatric help. I mean, how do you manage trauma? We're here with Ebola and hundreds of people, thousands of people died. We're here with COVID, people dying. We're here with mudslide, people dying. As a nation, we had 11 years of war as a nation. Everybody is traumatized. I mean, people don't even know how to talk to each other. Na Allah in the Allah. Also, you want to talk na Allah in the Allah, you know. Again, it's a result of some deep-seated stress that we haven't managed. So I think for us, we're looking at how do we look at mental health as a spectrum of care. How do we look at mental health not only as Kisi Psychiatric Hospital, but how do we look at mental health in school children? How do we look at mental health in pregnant women? How do we look at mental health in teenagers? How do we manage that within institutions and outside of institutions? How do we have counseling? So making very, very close partnership